Good morning. Thanks. First of all, I want to thank Thanos and, of course, Nur for choosing Spain and specifically Valencia for this 2024 ESD conference. My talk for today is why should we measure urinary pH in stone formers? And for that purpose, I'll try to follow this scheme. What's the relation between pH and kidney stones? When and how to measure urine pH? And pH-based urinary stones management. We all know that urine pH follows these variations during the daytime, and it depends on various factors, as nutrition, medication, drugs, genetic and metabolic diseases, and also gender. In this recent article, it was found that women have more alkaline urine than men only after feeding. A kidney stone would be the result of the balance between promoters and inhibitors. And that will give us the urine composition. But there are two other factors that are very important for a stone to form, which are pH and the time that the urine is inside the upper urinary tract. This is quite basic. We all know that with pH higher than 6.2, the precipitation of calcium phosphate increases very rapidly. On the other hand, uric acid urine is the perfect place for uric acid stone formation. And in between all those values from 5.5 to 6.2, what we call protective zone, and under supersaturation conditions, calcium stone formation can occur, and normally by heterogeneous nucleation. The core of the stone will be uric acid or calcium phosphate, depending on the initial pH value. So which are the causes of alkaline urine pH? These are normally or principally metabolic causes, renal tubular acidosis, some medication, alkalizing diets, and very important, urinary tract infection. We know that calcium phosphate stones are more frequent in women, and the principal risk factors are high urine pH and hypositraturia. The high urine pH will be independent of diet. So in an idiopathic calcium stone former and with hypercalciuria, low urinary citrate, and fasting pH above 5.8, as well as we find appetite to brucite stones, we should think about an incomplete distal renal tubular acidosis. We all know also the causes of acidic urinary pH, that are basically metabolic Orex syndrome, inflammatory bowel diseases, and exaggerated fitness training, leading to lactic acidosis or fluid loss. Okay, we know also that when in conditions of low urine pH, low urine volume, and high urine osmolality, we have a high risk for uric acid formation. It is in the early hours of morning, between 5, 6, that we have less volume, urine flow, and the pH is lower, and this is a critic time frame for uric acid stone formation. The uric acid, as I've already told, and you all know, has the pH range is between 5.3, 5.4. This graphic clearly shows also the solubility of cysteine, also depending on urine pH. The higher the pH, the higher the solubility. About crystalluria, we can see that all type of stones, but 2,8-hydroxyadenine and calcium oxalate stones are moderately or highly dependent on pH. Grasses and co-workers found that calcium oxalate dihydrate, calcium phosphate, and struvite was related to alkaline pH. And on the other hand, calcium oxalate monohydrate and uric acid were more related to acid pH. It would be heterogeneous nucleation that would explain how calcium oxalate is formed on uric acid at pH below 5.5 and how hydroxyapatite would form at pH over 6. Calcium oxalate papillary calculi was found to be independent of pH. And that would be in line of this conclusion from Wagner and Mohevi about idiopathic hypercalciuria does not display obvious problems in local or system pH regulation. Okay, when do we should measure urine pH? Most of the publications are about pH measuring in 24 hours samples. What most of this is quite a debate on that, because time and temperature will affect the urine pH. Some authors say that pH should be measured in the lab in the 2 hours after collecting the sample. In this study, they show that a spot sample pH measurement did not differ from 24-hour urine pH determination. So what Dr. Hess and co-workers found out after his long experience was that urine pH below 5.8 was considered normal, but this should be measured with a pH meter and after 12 hours of fasting in the second urine morning. And how do we measure the pH? What we know from literature is the strips are no longer advised in clinical practice because of its lack of accuracy. The Koenig and co-workers in 2018, and also Grasses and co-workers previously, they worked with a digital pH meter and compared the results of the pH measurement with strips and also with the lab pH meter. And they reached the conclusion that the new pH meter, the digital and portable pH meter, was reliable, accurate, and easy for the patient to handle. So we're talking about, as you can imagine, the lead control pH meter. And the results can be even improved for the patient with the use of these mobile applications. So what do we have for treatment and prevention? We have alkalinizing drugs. We all use citrates, bicarbonates, and now we also have available the theobromine. The aim will be different when we treat uric acid stones, if we intend to treat or if we intend to prevent. If we want to prevent, the pH level we will look for will be 6.2, 6.8, and to dissolve the stone, it will be a little bit higher. Potassium citrate and bicarbonate have always been used or are widely used for alkalinization. Allopurinol and febuxostat as inhibits the xanthine oxidase will be used to reduce uric acid. And now we have the theobromine as the new kid in this block. The potassium citrate, though we all know we have some side effects, as can be gastrointestinal, but also it produces a shift to a higher pH, which could result, or there's a risk for calcium phosphate stone formation. Here in this work by Coe in Chicago, can clearly see the shift up towards a higher pH when we compare the results after treatment with alkaline And the pink squares are after treatment, and the red dots are the initial results. You can see a rise in the pH. So it has been, and it's already been told before, that theobromine is very effective for prevent uric acid stone formation, as it and synergistically with potassium citrate, it can diminish by 12 times the formation of uric acid crystals. And it also works for dissolution, as have been already demonstrated in another paper. What to acidify? We have some other drugs like L-methionine, ammonium chloride, and this another nutraceutical that combines the L-methionine, vitamin A, phytate, and the aim with this medication is to decrease the urine pH. In the case of the struvite, our aim will be to prevent the stone formation will be a pH 7.2, and in calcium phosphate it will be 6.5, 6.8. It also, as already been told before, can help in, as canoxidine, in decrease stent incrustations, as have been shown in clinical trials by Torrecilla and co-workers. So to conclude, I would say that factors influencing pH are complex. Urine pH is key in stone formation. pH determination should be performed with pH meter, like leak control, because it's very accurate and it's portable. And the patient can do it at home and several times a day if possible. And alkalinizing acidifying drugs and theobromine help preventing both stone formation and dissolution. Thank you.
Thanks for this very nice informative lecture. I'm sure that everyone acknowledges now the pH value for stone formers. Any question or comment? I want to ask regarding the pH meter, because it's not available in many countries. I'm sure that you're using this in Spain. What's the price, and what's the compliance by patients? Are they happy with using it? Is it easy?
It's very easy to use because it takes just a couple of minutes. You have to control that with a buffer that it is working properly, and then just push the button once. You change the tip of the recipient, put it in the urine, and just press again. It takes seconds to have an accurate pH. It's very helpful for people who are recurrent and they have suffered many colics or interventions or whatever. They are very conscious of the disease. It helps a lot, and they want to use it. The problem, as you said, is price, probably, for me. Price about 100 euros, maybe a little bit cheaper now. But not everyone is willing to spend that money. They don't spend money for other things they can consider much better. But I think it's a point to improve, but probably in the future we'll do.
Also, I see the practical value. Maybe a doctor has it in his office, and when patients visit him, they can do a random test also.
Yes, because if they are conscious of the disease, they are empowered. The patient is empowered. It works much better. It's like testing your glucose levels after meals or before meals. That's the same. That should be the same thing.
Yes, you're right.
And doing it several times a day after meals, that would be of help.
Okay, so thank you. And